Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. By the time we reach our 40s, an estimated 10 million Americans have some degree of plaque buildup in their arteries, called atherosclerosis. Fatty deposits of that plaque in the arteries can impede or block the blood flow to the legs, called peripheral artery disease, or PAD, and you may not even know you have it. Today we're talking with vascular surgeon Dr. Jason Crowner from the MedStar Heart and Vascular Institute at MedStar Union Memorial Hospital in Baltimore. We're going to break down everything you need to know about PAD on this episode of MedStar Health DocTalk. I'm your host, Deborah Schindler. Thanks for being here, Dr. Crowner.
Thank you so much for having me.
To be honest with you, I've heard of arterial sclerosis, but I had to Google atherosclerosis because it's a term I'm not familiar with. How do they differ?
Well, it's a very similar pathology in the sense that arteriosclerosis is hardening of the arteries, where atherosclerosis is a specific kind of hardening that is secondary to fatty buildups or plaque, mainly from things like high cholesterol and hypertension.
Tell us how atherosclerosis contributes to PAD.
Well, atherosclerosis leads to the buildup of plaque in your arteries, and that plaque eventually causes narrowing in the vessels, and that narrowing decreases the overall blood flow or oxygen to things like your legs and your muscles or your intestines or your arms and your hands. And so basically the atherosclerosis causes that narrowing, kind of like if you used to watch the old Drano commercials and they showed the side view of the pipe keeps getting narrower and narrower so that the water doesn't run down. The same thing happens in our blood vessels where you just don't get enough blood.
How long does it take for that to happen?
It takes years. Sometimes it's faster in other folks. There's a lot of things that go into it. Some of the conditions that play into this are high blood pressure, high cholesterol, diabetes, smoking definitely.
So we know that narrowing of the arteries is going to be dangerous in some way. Tell me why it's a risk.
Well, most generally when we talk about PAD, we talk about it involving the lower extremities or the legs. The main symptoms for that is something called claudication. And what claudication is, it's pain in your legs with a set distance of walking. And what this usually feels like is a tight cramp or a Charlie horse in your calf that causes you to stop. And what that is that's your body telling you and your muscles telling you that you're not getting enough blood and or oxygen. And so usually this pain will go away with a period of rest. And so we call this claudication, and that's usually the main symptom or sign. But what can happen from there is that can progress to a point where you actually have pain in your feet or your toes all the time. We call that rest pain. Or you develop sores that are due to inadequate blood flow. And this can be compounded by folks that have other comorbidities such as diabetes. And so they're more prone to infection. And so they can get an infection involving their toes or their feet, and then that infection won't heal because of their peripheral arterial disease.
So more often than not, if they have a symptom, it's going to be some kind of cramping or a pain in their leg.
Yeah, generally most of the folks I see that are initially diagnosed with PAD is secondary to the claudication-like symptoms or the cramping in their legs.
It would be easy to dismiss the symptoms of PAD as a normal part of the process of growing older. How do we know when it's time to go see a specialist?
You know, I think that's a great question, Deb, and that's something that we actually try to educate all the other providers about, is because more often than not, you have somebody that comes in to see me, and what they tell me is that, well, I went to my primary care physician and they thought it was cramps from something else and they got treated for that. And months go by where they see several people and nobody checks their pulses to see if they can feel the blood flow or ask kind of the right questions. So I think a good rule would be if you feel like you can't feel your pulse adequately on your foot, or if you feel like you're getting the same pain at a set distance every time, then that would be something that I think should be checked out. That could be PAD.
Does varicose veins or spider veins or anything like that indicate peripheral artery disease?
No, they don't really go hand in hand. The difference really being that with PAD, what you're going to see in the leg is you're actually going to see a loss of hair. You're going to see kind of a thinning of the skin down there. You wouldn't have a pulse that you could touch or feel. The feet might feel cool, whereas with varicose veins or venous insufficiency, you're actually more prone to have swelling, engorgement of the veins, so kind of purpling tint of the skin, evidence of spider veins in that distribution. You're going to have leg swelling that's worse at the end of the day. They don't necessarily go hand in hand. Along with that, for the most part, with venous insufficiency or varicose veins, you shouldn't have pain with ambulation or walking.
Mm-hmm. So it does sound more serious than some people might even think, just by what you just described.
For sure. We have to remember that arteries take blood from your heart to the rest of your body, and veins take blood from the rest of your body back to your heart. And so those arteries that are taking that oxygenated blood to the rest of your body, that's something that we need, and those muscles need, and the tissue needs. And so it is much more serious from that standpoint than venous disease would be.
So if someone has some pain, some aches and pains, maybe in the same spot repeatedly as you described, that might be a sign of some PAD. What do? They go to the primary care physician, or should they go immediately to a vascular specialist?
No, I think going to a primary care physician is a great start. We work very closely with them, and we really actually lean on them to help us with the management and capturing these folks. It would be something you would bring up to your primary care physician. What they would do is a physical examination and a history. During that point, they should be feeling for your pulses. If they can't feel them, then the next step is something that's non-invasive called an arterial duplex or Doppler. And what this is just an ultrasound to look at the blood flow in the arteries going down your leg. And then it takes measurements, which are called ABIs around the ankle, to see what the overall blood flow getting to your ankles are. And there's set parameters for that we know that if it's less than, for example, 0.9 to 1 would be normal, less than 0.9 would be abnormal. And so if it's less than 0.9, then that would put you at risk of peripheral arterial disease, and that would be the patient that would then get referred to me. Along with that, the first approach or step towards the treatment of peripheral arterial disease is behavior modification and best medical management or therapy. And that would be an antiplatelet regimen such as an aspirin, a baby aspirin, treating the cholesterol, so putting the patient on a statin to help with the cholesterol, keeping their blood pressure under control, and then talking to them about behavior modification things such as tobacco cessation and then exercise therapy regimens. And so our primary care physicians really are kind of our teammates against this disease, because they help us with a lot of the other comorbidities that compound peripheral arterial disease and basically cause peripheral arterial disease.
What if I get an abnormal ABI score? What would your recommendation be? Should I be scared?
Well, I think the way I would answer that is twofold. I would say that if you're seeing your primary care physician and they get an ABI on you and it's abnormal, then most generally what they're going to do is refer you to somebody like myself, a vascular surgeon. And then from there, we're going to ask you a bunch of questions and kind of talk about whether or not you have clinical symptoms. And the clinical symptoms would be that claudication pain that we talked about. If you have an abnormal ABI, so remember less than 0.9 would be abnormal. Let's say your ABI is 0.7 or 0.8, but you have no clinical symptoms, then I wouldn't really do anything from an operative or invasive standpoint. What I would recommend is that you continue following up with your primary care physician. You continue doing the best medical management therapy with aspirin and statins and maybe even start a walking regimen. But the thing that I don't want you to think is that just because you have an abnormal ABI that you need a procedure. Because once myself, vascular surgeons, or anybody goes in and starts working on your arteries, either with those balloons or those stents that we mentioned before, the clock kind of starts. You know, nothing we do is ever going to last forever. And so we can actually kind of accelerate the natural history of the disease. Along with that, I never like the idea of doing a procedure on somebody and treating them and they don't even know that they're any better. So if you had an abnormal ABI, but you don't have any clinical symptoms, you're not at risk of losing your leg. So you shouldn't let anybody convince you of that and get a procedure that you don't need, that's unnecessary. Because at the end of the day, if you don't have any pain when you walk before the procedure and you don't have any pain at the day after the procedure, then you really haven't been helped very much. The only thing that's happening is that you've had your vessels manipulated, and that can lead to kind of downstream effects.
Yeah, I think that's a very important message, because people tend to think if I'm going to see a vascular surgeon or a surgeon, I must need surgery.
I agree. I mean, I think that I tell folks all the time that come in that actually have normal exams or normal ABIs that were referred to me maybe for claudication-like symptoms. And I'm like, I'm not the doctor you want to see. I love what I do and I love my patients, but I'm really not the doctor you want to see. And if you only have mild disease, then we might only see each other maybe once every year or longer. But there's a good chance that I'll never do a procedure or need to do a procedure. And with me, that's the best thing for the patient. And that's really what I'm here for.
So you're trying to postpone that as long as you can with other means, medicines or diet change, lifestyle changes. Very much so. I know it goes a little bit against me being a surgeon and not wanting or not always trying to operate, but I think that the most valuable lesson of surgical training is knowing when to operate. For folks that just don't have symptoms, there's really no reason to operate. Well, I want to talk more about the treatment, but I need to understand better the diagnostic process. You said a primary care physician might check a pulse. Are they checking the pulse at your calf, at your ankle?
No, the pulse should be palpable, which means you can feel it with your fingers, and it should be on the top of your foot. Just like if you put your hand on your wrist to feel your radial pulse, the same thing can be appreciated on the top of your foot, called your pedal pulses. Usually that's a pretty good indicator, if you can't feel those, that you may have some blockages or hardening of your arteries. After that, like I mentioned, the next step would be getting the ultrasound.
And that's the ABI?
The ABI is part of the ultrasound. So the ABI stands for ankle brachial index. And what that is it's a measurement. So they use a blood pressure cuff that's on your ankle and then a blood pressure cuff that's on your arm. And you take your ankle measurement and you divide that by the best brachial measurement, and that gives you a number. And that number is a reference to where you are on the scale of normal, mild, moderate, and severe peripheral arterial disease.
Well, that's interesting. The understanding being that your blood pressure taken from your arm is going to be different than that from your leg.
The understanding is that if the blood pressure is different than what is on your leg, then that demonstrates that you have some aspect of the disease. So, for example, if the pressure was 100 at your ankle and 100 in your arm, then your ABI would be 1, which would be normal.
Okay.
But if your ABI drops below 0.9, we call that abnormal.
Okay. What's the worst that you've seen?
0.
0 is the worst case of...
Yeah, zero being that there's just no blood flow down to your foot at all. And that can happen with cases of severe peripheral vascular disease.
In that case, what would you do?
Well, so generally after we get the arterial duplex and we figure out kind of what your numbers are and where the blockages are located in your leg, so kind of from your belly button down, that's really the arterial tree that we're looking at, then there's a few different approaches. Most generally, myself and what I would say most interventionalists or vascular surgeons go after is what we call an angiogram. And an angiogram is an invasive procedure where we use contrast dye to look at the arteries in your leg. This is done usually with moderate sedation, so such as some sleeping medication, but no breathing tube. We numb up the artery at the level of your groin, and called the common femoral artery, and we access that with a needle, and then inside of the vessel, we use contrast dye to take pictures of the arteries, and that gives us a nice outline of what the arteries look like. Now, when we do this, if there's blockages, I mean either narrowings in the vessel, so it's not fully dilated the way it should be, or there's actual blockages where it stops, kind of like if you were on a street that had a section that was closed. Through the process of this angiogram, we can actually help fix those vessels using balloons or stents. Balloons, just like it sounds, pop open the vessel or the narrowing, and then stents are kind of scaffoldings or new linings to hold open the vessel.
Can you see the atherosclerosis when you're doing those kinds of tests?
It really just depends on the severity, honestly, of the disease. So if there's a lot of plaque in the vessels, a lot of times you can actually just see that on fluoroscopy. And fluoroscopy is the process we use to visualize this. And the best way to think about fluoroscopy is like a continuous X-ray. And so you can see that plaque on the X-ray. Along with that, what you really see is the result of the plaque. And so you have a normal caliber vessel as it comes down, and then all of a sudden that either narrows to 10% of what it was above that, or it blocks off altogether, and then hopefully via collaterals or alternate pathways on the leg, that artery comes back. So the worse the ABI is kind of correlates with how bad the disease is going to be once we get in there and take a look.
So you go in and you stent it, or you use a balloon to open up the narrow artery. Then the patient can go home the same day?
Yes, ma'am. So these are all outpatient procedures. There's a few other tricks and things we have for fixing the vessels and devices that we use, but for the most part, those are kind of the tried and true, the stenting and the ballooning. After the procedure, you have to lay flat for a period of time, and then after that, you should be able to go home the same day, bearing no complications or problems. And
everything is done through the groin, through a cath in the groin. Mm-hmm. There's no open incision of the leg.
Not for this process. No, it's all done through a needle stick. The way I like to explain it to patients is that most everybody's heard of a heart catheterization. It's the same process, just for your legs.
Okay.
So everything's done through a needle stick.
Who's your typical patient?
My typical patient, if I had to describe the typical vascular patient, I would say it's somebody probably in their 60s to 70s who's a long-time smoker that has high blood pressure and high cholesterol, plus or minus diabetes.
Mm-hmm. While researching PAD for this podcast, I learned that incidence of peripheral artery disease substantially increased with every decade of life, actually doubling, and that between 2000 and 2015, the prevalence of PAD grew by 45% worldwide. but yet it is reportedly underdiagnosed repeatedly. This came from the Circulation Research Journal, February of 2022. Let's talk about that. Why are incidents of PAD on the rise, but yet it remains underdiagnosed?
I think, to answer your first part of that, Deb, I think that the incidence is on the rise mainly because of our aging population. And so as we have more and more people that are in that age of 50, 60, 70, 80, even up to 90, we're seeing an increase in the incidence of peripheral arterial disease. The other aspect is kind of goes back to what we talked about before, is that it's still just not the first thing that comes to folks' mind. When somebody comes in with pain, if we take back my vascular patient, so the 60 to 70-year-old person uses tobacco, has high blood pressure, has high cholesterol, generally when they walk in the door, there's a lot of other things kind of going off in your head as a physician that you see them that they probably could have going on, and other reasons for them to have pain. For example, they could have a sedentary lifestyle or not really get out and walk very much, and then they could be having discomfort just from overuse of their muscles since they haven't done anything for a while. Aches and sprains, as you know, happen. Arthritis is a big one that can really mask the signs and symptoms of peripheral vascular disease. So folks with bad knees, they get the same kind of distribution as pain. Having issues with your back can also have similar symptoms as peripheral arterial disease. And so there's kind of a slew of other things that can kind of muddy the water, so to speak. And so it's not always the first thing that physicians think about when a patient walks in the door.
I have to think, too, that diagnostics have improved so that it's easier then to diagnose a case, perhaps. You mentioned Doppler and the ultrasound. Oh, no,
yeah, for sure. I think the availableness of the arterial duplex and the Doppler, the ultrasound, it's everywhere. You could probably throw a stone from this hospital and find a place that does it, an outpatient facility or another hospital that will do that study and test for you.
So PAD affects women as often or more commonly than men, but according to research, too, women experience symptoms or are diagnosed later than men. Has that been your experience?
It has. This is actually a really hot topic in vascular surgery right now. And so I think all of medicine is looking a little bit more closely at gender differences, and so vascular surgery is doing the same. And what they've really found is that what we thought before was that being a male made you more prone to peripheral arterial disease and that it was more prevalent in males, but that's actually not the case. What we are seeing is that women who have peripheral arterial disease are more often asymptomatic and or present at a later stage. I'm first to tell you that my wife's a lot tougher than I am. And so, I do believe that women can probably put up with the pain in their legs much longer than a man would. And so by the time I see them, a lot of times the woman is to a point where she just can't hardly function or walk at all. They've waited that long.
Right.
So I think it's kind of twofold there. One, that they can have disease and clinically diagnose disease without actually having the same symptoms as men. Along with that, I do think that they hold off and they wait a lot longer before they go to the physician.
Shame on us. Shame on us. I'm as guilty as anyone for that. We're busy caring for others, we say.
Of course.
We just ignore our own health. What about other demographics? Are there other certain populations or ethnic groups that may be more prone to PAD than others?
Yeah, I think most of the minorities are a little bit more prone to it. And then I would say kind of low income folks are more prone to it. And the reason being is that the people of low socioeconomic standards, what happens is they just don't have the resources to maybe eat healthy, and they're going to be more prone to things like high cholesterol and tobacco abuse. They may not have access to healthcare or healthcare resources and be able to go to the doctor as often. Along with that, as we know, healthcare literacy is kind of a learned thing, and it's not always prevalent. If nobody tells you that eating McDonald's every day, for example, is bad, then you have no reason to know that it's bad.
It's cheap and on every corner.
It's cheap and easy. Yeah, of course, right? And then along with that, what we have found is that some minorities have a higher prevalence of things like diabetes. So, for example, the African-American population has a higher incidence or prevalence of diabetes, and diabetes can go hand in hand with peripheral arterial disease, along with things like high cholesterol. And so that's really where we see it. So I would say African-American patients or those minorities that are more prone to the other comorbidities, and also folks of a low socioeconomic status is pretty prevalent.
It's of a concern. What happens if it doesn't get treated? If it goes untreated, what happens?
Well, that's a great question. So if you present Well, let me answer this way. Let's say we screened everybody, and 60% of folks that we screened just here at Union Memorial today had evidence on the ABI that they had peripheral arterial disease, but only 10% of those were symptomatic. And so what I'm trying to say here is that just because you have evidence on a thing like a Doppler, a duplex, or an ABI demonstrating peripheral arterial disease, it doesn't necessarily mean you're going to have symptoms. Now, the 10% that have symptoms, about 30% of those are going to progress to the next stage of peripheral arterial disease. And we kind of say it as there's varying stages of claudication. So the claudication is the pain in your legs with ambulation that usually stops you, that decreases with rest. And we kind of have a mild, moderate, and a severe form of that, to the point that we call it severe when it starts to interrupt your lifestyle, meaning you just can't do anything because you can't walk hardly far enough for it to hurt. And so folks at that level will most likely progress to the next level where they actually have pain in their feet at rest, and they kind of have pain all the time along with coolness or numbness. If you don't do anything about it at that stage, then you're eventually going to get to the point where there's just an absence of blood flow to your foot. And usually at that point, if you don't get surgery, then it will result in the necessary need for an amputation.
Is it fixable if they come in and they have the hair loss on their leg that you described and severe cramping and complete blockage? Can that be fixed, or is amputation destined?
No. I mean, I think there's varying stages, just like everything. If I see somebody that only has mild claudication, so mild pain in it, they can walk 10 blocks before they get any pain in their legs. That's somebody we probably wouldn't want to do an operation on or fix at all. Now, if somebody comes in and they say, I haven't been able to feel my foot for the last month, then that's probably somebody that might not benefit from us doing surgery or not have any surgical options, honestly. But for the most part, yeah, if you present with symptoms and it's something that we can fix,
it can be reversed.
Yeah.
You can reverse the damage.
You don't reverse the damage. It's more like patchwork, I think would be a better idea about it. So you can help open those vessels back up and do a surgical operation called a bypass surgery, where you actually take blood flow from a good part of your body up high, such as your common femoral artery in your groin, and you reroute a vein or a prosthetic piece of bypass graft down to a place where the artery is good again. So you basically bypass the blockages that you have in your legs. We have pretty good outcomes with all these, the endovascular therapy and the open surgical therapies.
Is that a microsurgery when you have to do that bypass?
Well, my mom used to ask me that question a lot. It's not a microsurgery per se. We do wear these things called loops, which are the magnifying. If you ever go to the dentist, they wear the loops, the magnifying glasses, and we sew with this suture material called Prolene, and there's different variations of it. But we sew with 6-0 Prolene, which is about the size of a human hair. So in that sense, I guess it's kind of a microsurgery because we're sewing two blood vessels back together. But hopefully the blood vessels are bigger than the need for a microscope. I think that the neurosurgeon and the hand plastic surgeons, those are the folks that do the true microsurgery.
Do you love what you do?
Of course, yeah.
What kind of lured you into this direction when you were did you know that you wanted to be a vascular surgeon?
No, I think that's one of the funny things about vascular surgery is that it's just not overly well known. And I think most of us have a similar story. For me, I was in medical school. I wanted to do research, and the first person I contacted about doing research, and I got his name from one of the older students, was a vascular surgeon. And the first thing he asked me when I walked into his office was, "Do you know what vascular surgery is?" And of course, I had Googled it because I wanted to be prepared, but really I did not know. And so the cool thing about vascular surgery is it's a specialty that works on all the blood vessels in the body except for the heart and the brain, basically. And so you're just kind of all over the place. Along with that, the thing I love about my specialty is it's so multifactorial. I mean, it's the care of the patients and their comorbidities with their blood pressure and their cholesterol, and talking to them about, you got to quit smoking and you really got to out there and exercise. And then it's the treatment algorithms. And so, we're one of the few specialties that not only do the endovascular or the minimally invasive surgery, but we also do the open operations, which is the benefit of seeing a vascular surgeon. If we can't do the angiogram and fix you that way, then we can take you to the operating room. And then lastly, the thing that I truly love about my specialty is that, you see patients for a long time. It's not a one and done. They're not just coming in and getting something fixed and then you never see them again. I mean, these are folks that you can develop a relationship with, and They'll often be the people that come in and ask you to see pictures of your kids or vice versa. And so I like that. I like having those relationships and building that.
The long-term relationships, is that because they'll always have plaque, because they are going to always have this?
Yeah, it's kind of one of those things. Once you get to the stage where you're seeing a vascular surgeon, most of the time you're probably going to see them for the rest of your life. Along with that, I tell folks, I try not to operate as much as possible. And for mild and moderate claudication, the studies in the literature would suggest that we shouldn't operate, and that there's other things you can do, behavior modification, the best medical management that we talked about before, and then exercise regimens. And I always tell them that once we go in there and we do an angiogram, at that point forward, we're going to be lifelong friends, just because nothing that we do really lasts forever. And there's still going to be a continuation of that atherosclerosis, of that plaque buildup. Now, I will say that if you have a mild peripheral vascular disease demonstrated either by the ABIs or by your clinical symptoms, the use of an antiplatelet agent, the blood pressure control, cholesterol control, it doesn't necessarily reverse the overall process, but it will stall it and make it so it doesn't progress. And really, that's what we're aiming for.
What about blood thinners? Is that sometimes a requirement for treatment?
It can be. There are some studies that suggest there's times where we use the anticoagulants or the blood thinners to help with preventing propagation or worsening of the disease. But for the most part, we stick with the aspirin and the statin. Those are kind of our two. And then we have a medication called Plavix, which is kind of a super aspirin that gets used a lot for what we call dual antiplatelet therapy.
Now, you said that you like what you do because you're sort of working on all areas of the body.
Yeah.
Does peripheral artery disease affect other areas other than the legs?
Yeah, you can. That's actually a great question. I think when we talk about peripheral arterial disease, most people just gravitate towards the legs, but affects all the blood vessels in the body. And so that means you can have plaque buildup in the arteries to your arms, plaque buildup in the arteries that go to your intestines, to your kidneys even. And so it can happen everywhere.
What's the most unusual case that you've had?
I think sometimes when you get a CT scan and you see all the plaque in an aorta, which is the main blood vessel in our body, and all the branches, and you basically just see everything is narrowed throughout the entirety of a patient's abdomen. I think that's probably the worst.
So what's the fix for that? Surgery, apparently?
Well, it can be surgery. That's the other thing about our specialty, is that we see a lot of pictures and we see a lot of disease, and that the mainstay of our training is really that, we fix people, we don't fix pictures. And so there's a lot of times where I see a CT scan and I'm like, wow, this looks horrible, but the patient doesn't have any symptoms. And those are really the patients that you wouldn't want to do anything for. So just because it's bad doesn't necessarily mean it has to be fixed. Does that make sense?
No, I'd be afraid if I knew that I had PAD. I'd want it to be fixed. I'd want to get rid of it, or at least reduce it. Yeah,
I think the interesting part is that, as we talked about before, if we scanned everybody here at Union Memorial, there might be a ton of people that actually have PAD by the ABI diagnosis, but they may be clinically asymptomatic. And for those folks, those aren't the people that you would want to do an invasive procedure on. Those are the people you really want to start on the aspirin, you want to start on the statin, you want them to see their primary care physician and take care of the things that are going to worsen their peripheral arterial disease. I
was just going to ask, is there a way to reduce the risk of developing it or of it getting worse?
Heart healthy diet, clean living, try to exercise on a daily basis. And exercise can mean a lot of different things for different folks, but I think just walking for 20, 30 minutes a day is sufficient. Along with that, never becoming a smoker, or if you're a smoker, quitting smoking. I think it's important that, as we age and get older, that we see our primary care physician on a regular basis and really make sure that we're getting checks, just like you would, get checkups for your car and tune-ups and oil changes. The same thing needs to go for our bodies.
Is it hereditary?
Families that have high incidences of high blood pressure and cholesterol and diabetes are going to be those same folks that have a family history of peripheral arterial disease. And so if in your family heart disease, high blood pressure, high cholesterol, diabetes all runs and is very prevalent, then you're probably going to have all those comorbidities, which means you're going to be at a higher risk of peripheral arterial disease.
Now, if someone's had open heart surgery or a CABG or a stent indicating that they had a blockage to the heart, are they likely to, or should they get checked out for PAD in their legs?
Yeah, I think that's a great question. There is some correlation between heart disease and peripheral arterial disease. It's not a direct one-in-one, but what we know is that the risk factors for heart disease are the same as the risk factors for peripheral arterial disease. And so a lot of times folks that have heart disease, they do have peripheral arterial disease. Honestly, a lot of times we don't even find this until they get their heart surgery and they're in rehab and they just can't walk enough to participate in the rehab. And what we find is that it's because they have blockages in their legs preventing them from the long distance walking because they get that pain or that claudication that we talked about.
That's what I would be worried about. If I found out that I had PAD in my legs, I would worry about some cardiac event. Of
course, I agree. I mean, I think if you find out that you have peripheral arterial disease and it's affecting your legs, then the next step is just making sure that you're controlling it as best as you can with controlling your blood pressure and your cholesterol and following up with your primary care physician. And then, heart disease is kind of the similar thing as peripheral arterial disease. Is you almost have to wait until there's symptoms before you can do something about it. And so you can get monitored. You can check your cholesterol. You can check your blood pressure. Occasionally, practitioners will go ahead and do an echocardiogram or something to look to make sure your heart's functioning well. But I agree. I think if you have peripheral arterial disease, that would scare me as well. And I would want to make sure I'm trying to be as healthy as possible so that I don't have heart disease either.
What's the takeaway for listeners? What's the most important thing that you hope that they'll hear today? I think the takeaway for listeners would just be that, if you continue to have any of the symptoms that we talked about, so pain in your legs that happen at a set distance, or you can't appreciate or feel your pulse at your foot, or you just notice that your feet are always kind of cold and achy, or your legs are achy when you walk, then you might be at risk of having peripheral arterial disease, especially if you already have things like high blood pressure, high cholesterol, diabetes, or a smoker. And if that's the case, that might be something you would want to bring up to your primary care physician, just because the sooner we can diagnose and get a handle on it, the easier it is to treat and manage. Excellent. We've been talking with Dr. Jason Crowner at MedStar Union Memorial Hospital in Baltimore. Thank you for sharing your expertise with us here on MedStar Health DocTalk. Thanks for having me, Deb. For an appointment with a vascular surgeon at MedStar Health, call 410-554-2950.